everyone, and I bring greetings from ARH Chennai. Of course, I would like to thank the organizers before I start for inviting me, and very happy to be part of Diabetes India 2022. The topic that I'm going to be discussing today is sort of an extension of what we've listened to in the last couple of sessions from Dr. Nanditha, from Dr. Manoj, where they addressed inertia or clinical inertia in the management of diabetes, and that's what I'm going to be discussing further in general today, not just specifically for insulin, but in general as such. So I'm going to start off because at the end of the day, we're all here, we are all clinicians, and when we leave the hall today, I want us all to be able to apply this and take a carry home message to our clinics when we get back on Monday morning. So I want to start off with a clinical scenario. This is a Mrs. So-and-so who is 47-year-old, who is a homemaker, mother of 3 children, and she's been newly detected with type 2 diabetes. She's now sitting in the clinic with a HbA1c of 7.1, fasting of 128, postprandial of 189, and she has no comorbidities or complications at the moment in this consultation. So after discussion with the patient is hesitant, and this is very common, isn't it? How often do we find patients saying, no doctor, do I need to start off on medication now? Start medicines, will I have to take it lifelong? Isn't it? This is a question that most patients come up with. So this patient, not so uncommon, she was hesitant to start medication, and so she was advised with lifestyle modification only and advised to review after 3 months. But of course the story didn't end there. She comes back only 3 years later, and this time she comes with complaints of weight loss, and her HbA1c from around 7 that it was has now spiked up to 9.1, and at this point now she already has 2 complications, retinopathy and microalbuminuria has already set in. So what went wrong here? Was this absolutely avoidable, and who is responsible here? That's what we are going to be discussing here today. And this is exactly what is called therapeutic inertia. The definition of this is the failure to establish appropriate targets or to escalate therapy in order to achieve those targets. And therapeutic inertia is what is most of the time responsible for the complications which are most of the time preventable in patients with type 2 diabetes, with diabetes in general. And having said that, this is what brings us to the concept of the so-called glycemic burden. So here you see, don't know if my pointer is going to show up on the screen. Yes, it is. Great. So typically when we see the patient for the first time, we find the first HbA1c is below goal, and we are okay with that. In the next visit, the HbA1c subsequently then goes up, and then we don't act, take no action for whatever reason that might be. Next visit it further goes up, and this is the story that's usually happening. And this over here, the threshold above which the HbA1c then spikes up is what is called the glycemic burden, which is what is responsible for our increased risk of complications in our patients. And this is typically what we find in our in probably most patient scenarios, where we have the so-called stepwise approach, where initially, just like the patient that we saw in our first case study, we initially advise the patient on just lifestyle management, and then we wait until the next visit till the HbA1c goes up, and then we add one agent. Then we wait until the HbA1c goes up and then add the next agent. So every time we are actually reacting to a high blood glucose. Instead of being proactive, we each time wait for that HbA1c to go up, and then we take action. And in the meantime, the patient is being exposed to that amount of hyperglycemia and the so-called glycemic burden, which in turn is not going to give us very good outcomes. And we know that the best way to reduce the risk of complications, of course these are the landmark trials, I don't need to dwell too much on this slide, but we do know the take-home messages from these slides are that trials like the UK PDS, which is the landmark trial that showed us that in fact it is intensive glycemic control and early glycemic control that can reduce the risk of complications. We know that early intensive glycemic control will reduce the risk of microvascular complications, but when it came to the macrovascular complications, even trials like the ADVANCE, the ACCORD and the VADT failed to show benefit in terms of macrovascular. However, the UKPDS did show benefit in terms of macrovascular risk reduction only in the long-term post-trial follow-up, the so-called legacy effect, isn't it? Now, this legacy effect is what we learned from the UKPDS. But in a publication by Dr. Kamlesh Kunti et al., this is what they have termed as dysglycemic legacy. So from the UKPDS, we learned about the legacy effect. But here we're going, the legacy effect in terms of glycemic effect. But here we're going to talk about dysglycemic effect or the dysglycemic legacy. So what is that? In this study, which was very interestingly conducted, what was done was patients who were newly detected with type 2 diabetes received intensification of therapy within the first 1 year versus patients who did not receive intensification, in other words, did not maintain in the first 1 year HbA1c of less than 7%. So only for that first 1 year, the patients with intensive therapy versus non-intensive with less than 7% HbA1c. And at the end of 5 years, they actually found that there was a significant increase in cardiovascular outcome in the control arm with a 67% increase in MI, 50% increase in stroke, 64% increase in heart failure. So high cardiovascular burden when treatment intensification is delayed in the first 1 year after diagnosis. Now, how is the burden of diabetes in our country? I have to touch upon a little bit of epidemiology here. Do we think, yes, we all know that we have explosions of type 2 diabetes in our country. We know that there are large growing numbers of patients with type 2 diabetes. But are the numbers still growing? The answer is yes, absolutely. So here we have data that from our center that we've been publishing right from the 1980s. And we've been going back serially almost every decade to look at the prevalence of type 2 diabetes, not just in the urban, but also in rural India. And as you can see, the arrow is actually going upwards and we have exploding numbers. What are we doing about this is the question, right? At the same time, the drugs for the management of type 2 diabetes, we can't complain because we are in an era where we have also an explosion of drugs. Look at the evolution of management of type 2 diabetes. So with the evolution, you first had insulin, which was discovered 100 years ago, and then there was sulfonylurea, and then there was a lull, a period where there was no other agent that was available until metformin came back in 1990s. And then look at this spike in the number of agents that we have today. So we as clinicians treating patients with type 2 diabetes should not be complaining, especially in this era where we have at our disposal n number of agents to choose from, agents that are powerful to reduce the HbA1c, agents that are powerful to reduce the HbA1c without the risk of hypoglycemia, agents that offer benefit with not just reducing HbA1c but beyond glycemic benefit in terms of reducing the risk of complications. The SGLT2 inhibitors, the GLP-1 receptor agonists. So we literally do not have anything no excuse to not be achieving targets. However, this is data from Gare et al., which shows that among the multidisciplinary approach that we have, or the ABC, that is the A1C, cholesterol and blood pressure, still this is data from 2003, a long time ago, but where they showed that the target which is the most challenging to achieve is HbA1c. Among blood pressure, cholesterol, you can see almost 70% of patients, and this is true in our daily practice, we see this every day, isn't it? It's quite simple to control that cholesterol, quite simple to control the blood pressure, but somehow when it comes to blood glucose, it is very challenging. And let's look at data. This is global data. This is the percentage of patients who are not achieving targets, and it's quite, this is good news that we have here, that we are not doing that bad, so we should probably pat ourselves on our backs. Maybe conferences like this are really helping, where 50% of our patients are achieving a target less than 7% compared to high numbers like 80% in Algeria, almost 80% in Saudi Arabia, 75% in Malaysia, patients who are not. So merely hardly around 20% of their patients and 50% of our patients. But what about that 50% who are not achieving targets, right? This is a very interesting publication in which our center was a part of, in which it was a global study where it was a multi-center sort of model, in which what was looked at was the trend in prescriptions and trend in approach to type 2 diabetes management over the years? Is there a change in our trend of prescriptions over the years from 2006 versus 2015, over a decade? Because now we have so many agents, have our patterns of prescriptions also been changing? And this is the results of the study. And this is data that you have from India, which I've highlighted here. And if you look at comparing 2006 versus 2015 over a period of 10 years, yes, we are improving. If you see the red bars, there is an intensification in terms of increase in insulin therapy, and we are treating with more aggressive triple drug therapy as compared to 2005, and our monotherapy and diet only has actually come down. So we are actually trying our best as physicians to intensify. We are intensifying our approach. And in the bottom over here, you see the change in HbA1c when we compare India to other countries like South Africa, where there has been from 2000 over a period of one decade, there's actually an increase in the HbA1c of patients with type 2 diabetes, whereas in India, there's actually a significant reduction in HbA1c levels over a period of 10 years. And these are the patterns of prescriptions. So if you compared 2006 versus 2016, the percentage of of course, SGLT2 inhibitors were not available then, but 16% prescriptions of SGLT2 inhibitors. This is the percentage of increase. 20% with meglitinides, alpha glucosidase 22%, and 2.8% of GLP-1. So we are actually underutilizing the GLP-1 as compared to a whopping 10% in Australia. But compared to Hong Kong, we're doing much better. So we are prescribing GLP-1 receptor RAs quite well, I'd say. 40% of our patients are on DPP-4s, 77% of our patients on sulfonylurea, and metformin increase seems to have increased from 60% to around 90% of our patients are on metformin, which means that we're actually doing pretty well. So our patterns of prescriptions have changed, and we are definitely trying our best to intensify therapy. But is it good enough is the question. So where is the root of the problem? When it comes to therapeutic inertia, where is the problem actually? There are several reasons, and it can be either clinician related, patient related, or the healthcare system related. Clinician related the reasons would be insufficient time, isn't it? And just like Dr. Neeta was just saying, we are all so busy in our practice. We don't sometimes see the patient as another person, and when the patient is hesitant to start medication, we sometimes just dismiss it and say, because we need to see the next, we have a whole number of patients waiting outside, so we really don't have the time to spend that much, isn't it? The next is the patient hijacks clinical visits, and this is something similar to what we saw in our case study, where patients themselves are hesitant, and they sort of take over the consultation and say, doctor, don't worry, I will show you next time, isn't it? Next time I will bring down my HbA1c. Don't worry, doctor, leave it to me, I will take care, isn't it? It's because I had some weddings, I took some sweets, my granddaughter's birthday party, or whatever it is. There's always an excuse. So this could be one of the reasons, and many a times we also don't want to lose the patient. When it comes to treatment intensification, if we enforce, and if we are forcing patients when they are not willing, sometimes the patient might just go to the next doctor, isn't it? So that itself is one of the reasons why many clinicians, I think, just don't want to be too harsh, or they're just the fear of losing the patient itself. And then, of course, the reactive instead of the proactive approach, which I already addressed. The patient-related reasons would be denial of the disease, lack of health literacy, medication-related, very, very important, where side effects of medication, too complex regimes where we give them multiple shots of insulin per day, or multiple tablets, or the pill burden is too high, or costly medication in our part of the world especially. And last but not the least, and this is something that's very, very important, absence of symptoms. We must remember that diabetes, especially type 2 diabetes or hyperglycemia, can be asymptomatic, and we all know that. So for the patient sitting in front of us, taking that shot of insulin or taking that oral agent is not rewarding. When the patient has a headache, he's anyway going to take in that paracetamol, or if he has a tooth pain or whatever, or a stomach pain, he's going to take that tablet. Even for blood pressure, sometimes they're symptomatic and they say, oh, I have a headache, maybe my blood pressure is high, and they take in the tablet. But when it comes to anti-diabetic agents, taking their medication is not rewarding. So what keeps the patient motivated, chronic, for their entire lifetime to take their medication? isn't it? This is something that we need to think about and probably spend time explaining to our patients the importance of adherence to their prescriptions. And then of course the healthcare system could also be something that may be a reason for it, where we don't have supportive staff, we do not have patient educators, nurses, and so on. So the solutions to therapeutic inertia would be to have, as far as possible, to find solutions to those problems that I just discussed. Maybe try to spend more time with your patients. If you do not have the time, invest in a patient educator or a nurse or just someone who can explain to your patients and spend some time clearing their doubts. For patients who have fear of injections, maybe improved devices. All these are various approaches, and a psychologist or basically an integrated approach that could actually help with overcoming therapeutic inertia. And last but not the least is of course apps and mobile technology, or the application of technology in diabetes. And there's a big boom, of course, we know, with all the apps. There's been some discussions even today in some of the sessions about mobile apps and their roles in improving patient outcomes. So we had actually, I'm just going to end with this last part of my talk, which is one of the studies that we had actually conducted to actually look at the role of improving adherence to prescriptions through simple mobile phone text messages. So patients who were newly detected with type 2 diabetes, around 250 patients, were randomized into two groups. Both the groups received standard of care, but only one group, the patients received serial text messages on their phone, just basically reminding the patient to adhere to their prescriptions and to take their medication regularly. Just simple text messages in the local language or in English, twice or thrice a week, to remind the patient. And at the end of the study, we found that there was a significant improvement in HbA1c in the intervention arm, that is the SMS arm, as compared to the control arm, and a significant improvement in the fasting plasma glucose in the intervention arm. So simple text messages on the mobile phones actually helped in improving patient adherence and in turn improving outcomes in these patients. So in summary, we do have a huge burden of type 2 diabetes, especially in our part of the world, and not just in the urban but also in the rural areas. And we have, in spite of so many newer agents that we have available, and in spite of our trends in prescriptions, we of course are trying our best to intensify therapy, but somehow we have to identify what is going wrong, identify where the inertia is actually existing. Think about the fact that the whole dysglycemic legacy is also equally important, and early intensive control is extremely crucial to reduce the risk of complications. Simple solutions like maybe having a patient educator, patient education programs, improved devices, and like I showed you, the role of technology also could go a long way in combating therapeutic inertia and thus improving outcomes in our patients. Thank you.